Okay, so this is our final lecture on chapter 47, and it's just going to go over some of the other effects of mechanical ventilation on different systems in the body. The first system that we're going to cover is just a cardiovascular system because the heart and the lungs are roommates. They occupy kind of the same space in the thoracic cavity. So things with ventilation or any alterations to the way that we normally breathe are going to have probably the first impact on the heart. So, studies have shown that there can be a marked reduction in cardiac output based on the amount of positive pressure that we're applying to the lungs. Okay. So, the more pressure I apply to the lungs, positive pressure I'm applying in the lungs, the more my cardiac output is going to be reduced. And this is because if you think about it, like I said before, your heart and your lungs are roommates. They kind of take up the same space. So if you think about your heart being kind of a box within a box, so this is my thoracic cavity. These are my lungs. And then this is my heart. Okay. As my lungs expand from that positive pressure, it's going to put pressure on the outside of my heart. It's also going to put pressure on all of those big veins that are taking blood back to the heart, like your superior vena cava, your inferior vena cava, and that's going to cause venous pooling in the peripheral parts of our body. Okay. So if blood stays up here in my brain, blood stays down here in my periphery and doesn't come back to the heart, that then is going to mean that blood's not coming into the heart. So then blood can't be bumped back out of the heart. So my cardiac output decreases. Because blood is pooling up here, my cardiac, that can have an increase in my ICP or my intracranial pressure. So blood is pooling up in my brain, my ICP increases, my intracranial pressure increases. Okay. Because there's so much pressure up here, new blood, new perfusion isn't going to be able to come up there. Everything goes path of least resistance, areas of high pressure to areas of low pressure. So if my pressure up here in my brain is so high, new blood is not going to be able to get pumped up there. So new oxygen, new nutrients aren't coming up to the brain, which is going to lead to cerebral ischemia, which means no blood flow or hypoxia. Okay. So in normal patients, our brains are usually able to regulate that pretty well. But in patients that have had traumatic brain injuries or strokes or other things like that, their ability to regulate the pressures in their head are going to be messed up, for lack of a better term, and that auto regulation won't work, and you'll see very, very, very high intracranial pressures on those patients. Our body does have compensation mechanisms to try to minimize the effects of this cardiovascular effects. So if you think about it, blood's going to come in here and then it's going to be pumped out. The amount of blood that gets pumped out with each beat of the heart is your stroke volume. Okay. So that gets reduced. Our stroke volume is getting reduced when you put somebody on positive pressure. Okay. So my body can compensate for that low stroke volume by increasing my heart rate. Because your heart rate times your stroke volume is what equals your cardiac output. Your cardiac output is how much blood leaves the heart every minute. So when one is low, so when my stroke volume decreases, but my heart rate increases, that helps me maintain a normal cardiac output. The other way my body compensates is by increasing my systemic vascular resistance. So if the pressures in my periphery, if I increase that, I can try to keep my blood going back to my core organs better, right? We want to maximize the blood that goes to the important things, not, perfusing my fingertips. Okay. Okay, so your pulmonary vascular pressure or your blood flow and everything within the heart or within the lungs, um, normally, again, if your patient has a normal cardiopulmonary system and they're just receiving mechanical ventilation at not too significant of pressures, you're not going to have any decrease in pulmonary blood flow. However, if those alveoli get over distended by either high volumes or high peeps, that pulmonary blood flow gets compressed. Okay, so this is this imagery I want you to have. So if you think about your alveoli, and then it's surrounded by those pulmonary capillaries, when those alveoli get over distended and get bigger from positive pressure, they're going to bump up against these pulmonary capillaries and block the blood flow here. Okay, so when that happens, that increases my pulmonary vascular resistance. And when my pulmonary vascular resistance increases, that then increases the pressures, the afterload on the right side of the heart. So it increases right heart pressures and decreases things that are downstream, which is my left side heart pressures and my cardiac output. Okay. So it's interesting to note, though, that the patients that are at more risk for this are actually your patients who have like higher lung compliance. So your COPD patients are going to have more risk for this because they have more risk for overdistension. Your emphysema patients specifically have more risk for this because they have more risk for overdistension than your ARDS patients. Okay, so COPD, emphysema has higher risk due to that really compliant lung than your ARDS patients who have really stiff lungs. Okay, because I can apply a lot of pressure to a stiff ARDS alveoli where it will never compress that capillary. But my COPD patients, they're at very high risk for overdistension. Okay. So your right and left ventricle function, again, under normal conditions, normal patients, there's not going to be any significant change to this. But if you have the patient that's hypovolemic or needs excessive amounts of tidal volume or excessive amounts of PEEP, that's going to impede that blood flow and venous return. So PEEP, that excessive amount of PEEP is usually the biggest culprit because that's the pressure that's always in there. Interesting, your book points out that the effects of the left ventricle dysfunction actually may improve with the application of positive pressure ventilation. So left ventricles, because that afterload sometimes gets decreased when you add positive pressure ventilation, that you'll sometimes see your congestive heart failure patients do better and have better cardiac output, get better ejection fractions when they're on the mechanical ventilator, but then when you take them off, it starts to decrease again. Okay. All right. And then again, your endocardial blood flow may also be affected because any factor that decreases your systemic blood pressure or increases those wedge pressures in the lungs is going to decrease that endocardial perfusion pressure. Okay, so that is the blood flow to the heart tissue. All right. Just talk a little bit more about cardiac output, cardiac index, and systemic blood pressure. So your cardiac output is the amount of blood that leaves the heart every minute. Your cardiac index is that blood kind of applied to the patient's body surface area. So if you think about it, I'm 5'3", 4 liters of cardiac output should be sufficient for me, maybe sufficient for me, but that same 4 liters in Shaquille O'Neal would be insufficient. So that's where cardiac index comes into play. And your systemic pressures should kind of, even though you might have lower cardiac output, your systemic pressures, because of that increased vascular resistance, could look the same or could look adequate. Okay. So you want to make sure that you're still making sure that your patient has adequate fluid balance and that we're managing the ventilator with the lowest possible pressures necessary. Okay. We also use vasopressors in patients in the ICU a lot to try to keep the blood pressures sufficient. Okay. Most cases where you have a patient that's hypotensive during mechanical ventilation, it is usually because of sepsis. Okay. Sepsis is going to cause peripheral vasodilation, and that is going to then cause a patient to be very hypotensive, which can be significant for patient outcomes. Okay. So how do we minimize the effects on the cardiovascular system? And it really is with minimizing our pressures and making sure we have adequate fluids. So we are minimizing the pressures that we're applying to the lungs whilst making sure that we're supporting that cardiovascular status with fluid resuscitation. So mean pleural pressure, this is clinically monitored as your MAP. Like I've talked about before, this is the average pressures in the lungs. Okay, so the higher the mean pleural pressure, the greater the cardiovascular side effects. Okay, we already talked about that this can be minimized if you have very non-compliant lungs in your ARDS patients, and even high increases in your pressures on most patients might have minimal effects. But if your patient has already cardiovascular issues like hypovolemia, that can have a very big negative impact. Okay, so okay. Okay. So how do we minimize the pressures in the lungs? And this is really talking about, again, that mean airway pressure. So I've drawn this up for you before. Your mean airway pressure is pretty much anything underneath the area underneath that pressure waveform. So the things that are going to affect this are your tidal volume, your respiratory rate, your I time, any pauses you take, your expiratory time, your ID ratio, your PIP, your PEEP, your inspiratory flow pattern, all of it. All of that affects it. So it's a whole area underneath this curve. So changing any one of these things is going to change your mean airway pressure. Okay. Typically, the biggest thing that we do is changing our PEEP. As long as our PaO2s are adequate, reducing our PEEP is effective at reducing our mean airway pressures. But we do want to avoid desaturation. Okay, so we need enough PEEP to keep that alveoli open, but we don't want to have so much PEEP that alveoli is compressing our pulmonary blood flow. Okay. If we, we can help manage that by, using, excuse me. You can help manage your PEEP by, doing lung recruitment maneuvers. You can use diuretics to try to help with tissue compliance, things like that. And you could also potentially look at decreasing the tidal volumes that you're using, the pressure control levels, anything that's going to reduce the area under this curve will reduce your mean airway pressure. That's pretty much all I have to say about that. All right, so fluid management, cardiac output. This is the other side of that, and we want to make sure that our patients have enough fluid pumping through their bodies to keep good blood volume. So we talked about the Franklin-Starling phenomenon before, and that's really talking simplified. That's really just talking about preload, the amount of blood going in, the contractility of the heart muscles, and the amount of blood, the resistance that the blood has to meet going out. Okay, so when a patient receives mechanical ventilation, there's a risk for that decrease in the preload, the venous return, because of those increases of pressures. So that causes the stroke volume to decrease and decreases kind of the ability of the heart to maintain good cardiac output. Okay. So if you have a patient that's kind of has high risk again of hypovolemia, like shock, sepsis, then those patients usually need to have fluid or blood administrations to maintain that cardiac output. Okay, so pharmacological maintenance for cardiac output and blood pressure. So first line is always going to be fluid, except in patients with CHF. But other things that we do is we can give them like inotropic therapy that decreases the myocardial contractility. We also give vasodilators and diuretics to control hypertension and decrease that afterload. We use diuretics again to control fluid overload and decrease preload in that overly distended heart. So all of those types of medications are useful when trying to manage like complex cardiovascular patients on mechanical ventilators. Okay, so moving on to the brain. We already talked about increased intracranial pressures. So the things that are going to affect your intracranial pressures are going to be like your cerebral perfusion pressure and or ICP affects your cerebral perfusion pressure. So if your ICP gets too high, then your blood pressure, the pressures that are pumping the blood up to the brain aren't going to be able to overcome this. So your book kind of talks about it like this. Get my thingy. So CCP is your cranial perfusion pressure. Okay, we want this to be adequate so our brain gets blood. We want this. Okay, the things that are going to affect this is your mean airway pressure and your ICP. Okay, so when my mean airway pressure gets too low, that is going to decrease my cerebral perfusion pressure. When my ICP gets too high, that is going to decrease my cerebral perfusion pressure. Okay. If that CPP decreases, that means that your blood's not going to get or your brain's not going to get blood, and you're going to have that cerebral ischemia and that low cerebral O2 metabolism, which is bad. Your brain's not getting blood. It's not getting oxygen. It's going into anaerobic metabolism, which can lead to anoxic brain injuries. Okay. So typically this is auto-regulated, but if your patient has had any type of um uh brain injury or anything like that, that can greatly reduce this. Okay. We do sometimes treat brain injuries by um and clonid head injuries by hyperventilating the patient. So acute hyperventilation can help control ICPs. Okay. So, so hyperventilation only works in the short time. So it shouldn't be used as a long-term um, tactic to decrease elevated ICP. Okay. So typically those long-term things are going to include drainage, drain tubes. You might do like a surgical procedure to open up the skull to relieve some of that pressure. And with patients with traumatic brain injuries, you always want to be very, very careful to not do things that might agitate them and increase their ICP, like suctioning, repositioning, other types of stimulation. Intubation should only be like attempted in traumatic brain injuries after the patient's been sedated to try to keep those ICPs less than 20. Okay. For the effects on the kidneys, um, because positive pressure ventilation is going to affect um, blood flow and cardiac output, there is going to be reduced blood flow to the renal systems. And then that can, if the kidneys aren't being perfused, they're not going, kidneys need a lot of blood to work. So that's why you see a lot of your mechanical ventilator patients in kidney failure or renal failure because kidneys need a lot of blood to function properly. So when you put them on positive pressure ventilation, that is going to reduce the blood flow to the kidneys, which can then reduce the urinary output by 30 to 50%. Okay. Um, it also can be related to like excessive amounts of sodium and potassium excretion. And due to the fact that positive pressure ventilation has been shown to decrease like a hormone that is like a diuretic hormone that we have in our body, which is called ADH, which is your God, what does it stand for it again? Your antidiuretic hormone. So it increases the secretion of that vasopressin antidiuretic hormone, and that also decreases urine output and causes fluid retention. Okay. Same thing with the liver and your spleen. Um, this is going to be directly related to the effects on the cardiovascular system. So liver dysfunction comes from when your reduction in that hepatic blood flow. Okay. So if you are using too much of excessive PEEPs, you're going to have decreased liver function, decreased renal function. Okay. You can also have issues with the gastrointestinal system. So if you aren't getting blood flow to the good blood flow out, you can have patients that can get stress ulcers caused by that impaired blood flow. They can also get these stress ulcers um, or they can have like gastromotility issues where things aren't kind of moving along in the GI system like they're supposed to. That can kind of negatively impact like bacteria in the blood. or in the gut, and cause gastric distension as well. They can have gastric distension also because of, excessive amounts of air ending up in the stomach. So if you think about, um, anybody that's on mechanical ventilation, that positive pressure ventilation is going to go path of least resistance. So we want it to go to the lungs, but if you have a leak around the cuff, that's some of it's going to end up in the stomach and cause some excessive amounts of distension. Okay. So a lot of times patients that are um, on mechanical ventilators are prophylactically treated for these ulcers because of their risk. So a lot of times you've seen patients that are on, um, God, I'm trying to think of what the medication we're seeing a lot used now. But a lot of times on your med list, for your case studies, you're seeing patients on gastric acid reducers, and that's just a prophylactic treatment to try to help with stress ulcers while the patients are being mechanically ventilated. So, being in the critical care environment is going to have negative impacts on the patients just in general, central nervous system. There's going to be a lot of anxiety and fear and agitation involved in this just due to like loss of control of what's going on. I mean, imagine yourself laying in a bed, kind of inner strains, tons of tubes stuck in you, lack of control over what's happening with you. That leads to a lot of agitation and fear with our patients. Also, that inability to communicate effectively has a bad impact on our patients. So we always want to try to do our best to have communication boards, paper, pen, and tablets in the bedrooms to help our patients or ease our patients' fears as much as possible. So our patients are going to be given medications for sedation. They're going to be on medications like sedatives, hypnotics, and neuromuscular blocking agents, possibly. The level of sedation that a patient's receiving should be monitored very closely because excessive amounts of sedation is going to lead to like ICU delirium, and like that's going to impact positive outcomes for the patient. So delirium has been shown to increase mortality, morbidity rates in the ICU, make it longer for the patient to recover. So we really want our patients, the goal is to keep our patients calm and comfortable, not completely snowed, which has kind of been a change in practice a little bit. So we want him to be kind of at that level 3 on the Ramsey scale where the patient's responsive, yet not restless or agitated, but also not paralyzed and comatose. Neuromuscular blocking agents are used to paralyze the patient. So these paralyze the patient, but the patient's still fully aware of their surroundings. So we don't use neuromuscular blocking agents on every patient. They're just used, in cases where we really don't want our patients moving around a lot. Usually it's those patients with high ICP levels. Opioids are used for pain. So sedatives are used to kind of calm our patients down. Neuromuscular blocking agents are used to paralyze their patients, and those opioids are used for pain. So there's a lot of painful procedures performed in the ICU. We want to make sure that we're treating that as well. A lot of times when you go into your patient's room, and if you notice that they're hypertensive or tachycardic, but they're on sedatives and or neuromuscular blocking agents, maybe they have some underlying pain that needs to be treated. I would start making yourself a list of, common neuromuscular blocking agents pain meds and sedatives that are used in the ICU and start memorizing those. Those will probably come up on your MBRC exam. Okay, so this is just, there's a chart in your book on page 1044, box 47.3, that talks about that modified Ramsey sedation scale. So we want our patients to be kind of at a 3 is where we would like most of our patients to be. Oh, I already said this. All right. Okay. So we talked about all the different side effects to the body systems. Most of those are related to positive pressure ventilation, but just some complications that patients can experience with negative pressure ventilation, those chest cuirasses, iron lungs. They can have pulmonary complications. Usually this is related to an inadequate seal. So in order for that to work properly, it needs to be sealed tightly. To be able to generate the negative pressure to pull the chest open. So hypoventilation can happen due to inadequate pressures from leaks. And you can also hyperventilate your patient if there's too much negative pressure used, which is true too of positive pressure ventilation. We can have hypoventilation if we have a leak in the system, and we can have hyperventilation if we're using too much pressure. So that's kind of a shared complication. Cardiovascular complications related to non-negative pressure usually are with abdominal pooling. If you think about it, the abdomen and the thorax are both included in this chest cuirass. So blood is going to want to go to areas of least resistance. So negative pressure areas, you can have pooling of blood then in the abdomen, which reduces venous return, reduces cardiac output, and blood pressure. That's sometimes called tank shock. And then kind of just the other side effect is just the isolation patients feel with being put in negative pressure ventilation. They live in these tanks. Their head's the only thing that's sticking out. There's not a lot of interaction with the outside world. So there's a lot of, I think, psychological side effects too for these patients, just with the isolation of being on these devices. So complications related to pressure. So we talked about this is your positive pressure ventilation again. So in chapter 37 of your book, we talked about artificial airways and the issues you can have with those. But you can also have just positive pressure issues where your patient can get ventilator associated lung injuries, which is, I'm applying too much pressure to the lungs, is causing, I'm either causing inflammation or injury. Patients that get ventilator associated infections, or if they're experiencing asynchronies with events, they're going to be more likely to have those lung injuries. Barotrauma is the term we use for any high pressure injuries. So these are going to include things like pneumothorax, pneumomediastinum, pneumopericardiums, and subcutaneous emphysema. So all of those complications are really just where the air escapes the alveoli due to a leak and ends up where it's not supposed to. So those alveoli rupture due to too much pressure being applied to them, and it escapes and ends up somewhere it's not supposed to be, and kind of we define what type of trauma it is, which one of these it is, based on where it ended up. So remembering with pneumothoraxes, we've talked about these before. To identify these patients, they're going to have that decreased chest movement. Usually it's notable on one side, more on one side versus the other. They're going to have that hyper resonance to percussion, meaning that it's going to sound kind of tympanic on the affected side. If it's a tension pneumo, remember it's a medical emergency, so it needs to be needle decompressed right away and then have a chest tube put in. Sometimes some studies have shown that by putting the patient in 100% oxygen at low tidal volumes or low pressures, that helps reabsorption because oxygen gets absorbed into the blood, but nitrogen doesn't. So if you're there at 100% oxygen, that can help with reabsorption. We used to do that a lot in the NICU. That's why oxyhoods were, everybody was such a fan of oxyhoods for so long. Okay. Complications related to volume. So you have volume related and volume related injuries. So you have this is kind of described as an increased permeability of that alveolar membrane. Okay, so pulmonary edema, cell wounding, necrosis, and other alveolar damage is the result from using too much volume or overdistending those alveoli. Okay. So volutrauma is usually the word that we use for that. So that's where we're using too much pressure, too much volume rather than too much pressure. Okay. You can also have atelectrauma. This is where lung damage is occurring because we're not using enough volume. So the alveoli are allowed to deflate and reinflate and repeatedly with each breath, and that's called atelectrauma. Okay, so this is where using more PEEP might be appropriate to try to keep those alveoli open so that you're not opening and closing and opening and closing and opening and closing. Okay. So there's several factors that might kind of predispose patients to having volutrauma. They could be having inflammation already, systemic inflammation already due to like sepsis. They could have surfactant dysfunction, and we see this in preterm babies where they don't have enough surfactant produced yet. They could have had aspiration where they have stomach gastric content or other content in the lungs that kind of neutralizes the surfactant and doesn't keep those alveoli open. Pulmonary edema also neutralizes your surfactant, makes it hard to keep your surface area, surface tension in the alveoli and keep your alveoli open. Extreme ages again. Your premature babies, your really, really elderly patients are going to be more susceptible to this. And then if you have different types of heterogeneous lung ventilation, where you have areas of the lung that are compliant versus non-compliant, and that's causing most air to go to the compliant sections. Okay. With that uneven distribution. Okay. Okay. Sorry. So biotrauma really talks about that secondary release of those inflammatory mediators. Okay, so the lungs are stretched, and that sends kind of signals to the brain, and it releases these substances, these inflammatory mediators, resulting in inflammation and causes biotrauma. Auto PEEP is the term we use if you have not enough expiratory time, which results in the expiratory flow not going back to baseline and air getting trapped in the lungs. Okay. Your risk for auto PEEP is going to increase when you have increase in airway resistance in those obstructive disorders, or if you have that increased lung compliance, as I showed you guys in lab the first week, where the lung compliance is really, really high. There's no elastic recoil to try to encourage that air to leave. So usually auto PEEP is not going to be included in the measure or displayed PEEP value, so it can be easily overlooked. So you need to do that expiratory hold to see it. This is going to increase the work of breathing by decreasing that diaphragm's effectiveness, making it difficult to trigger the patient's ventilator. Okay, so if you think about that, let me see if I can draw this out. So with your patient ventilator, this is your pressure waveform here, okay? Your patient baseline should be at 5, okay? But like I said, the vent thinks the patient's baseline is at 5, which what we have set with the PEEP. But let's say we have an auto PEEP of 7. That really truly raises that baseline to 7, but the vent's not aware of that increased raise. So now the patient, if the patient has a pressure trigger set at 1, okay, so the vent thinks that it needs to sense a pressure of 4 off the baseline in order to trigger a breath. But if the patient has an auto PEEP of 7, they really have to suck in. It's still 4 that the vent has to sense, but instead of sucking in 1 centimeter of water pressure here with no auto PEEP, they have to suck in 3 centimeters of water pressure there. Okay, so we minimize our risk of auto PEEP by increasing that expiratory time. We do that by decreasing our I time, or we can increase our PEEP set until the patient can then trigger the ventilator. Okay. Oxygen toxicity happens when the lung tissue is damaged due to high levels of O2 being delivered to the airways. So this is going to increase that permeability of that AC membrane and could result in pulmonary edema and inflammation. So this patients are at risk for having this when they are ventilated at FiO2's greater than, this should say 0.6, not 0.5, greater than 60%. Ugh. Sorry. That greater than 60% for more than 24 or 48 hours. It should say 60. Okay. Yes. I'm just going to do this. Greater than 60%. Okay. In presence of that high concentration of O2, those O2 free radicals are produced. Those free radicals then are going to cause that increased permeability of the AC membrane. So it's going to cause a kind of a direct lung injury, decrease that surfactant production, and subsequently decrease lung compliance. Ventilator associated pneumonia. This is another complication that we're very, very much aware of. This is pneumonia. Pneumonia is kind of a second most common nosocomial infection. So these are infections that happen in the hospital. So our patients that are on the ventilators are very susceptible to this due to kind of micro aspirations from the upper GI system. that occur around the cuff or around the ET tube. So to prevent VAP, we want to do gentle suctioning, use other recommendations are to use MDIs rather than small volume nebulizers to prevent breakages of the circuit, keep the head of the bed up 30 to 45 degrees, change the circuitry as least amount as possible, avoid or drain any inspiratory tube condensation. So when you see all of that water, that's condensation building up in the inspiratory limb, make sure you're draining it back to the humidifier so it doesn't get to end up in the patient's lungs. And then probably the best thing for them is to get them off the ventilator as quick as possible. So there's actually quite a few studies out there on different ways that we can help prevent this. Different types of endotracheal tubes, cuffs have been used or studied to look at this. Big takeaways: head of the bed up, closed suction systems, don't break the circuit, and make sure that you have those adequate cuff pressures. Okay. Okay, ventilator malfunctions are categorized as a failure in either the patient circuit or a failure in the ventilator. So failures in the patient circuit include anything related to the ET tube, so cuff leaks, right main stems, laryngeo, intubations, esophageal intubations, soft tissue erosion from the cuff being too high, disconnections from the circuit. Failures in the tubing are anywhere there's a leak or in the actual circuit, or a leak in any of the connections with nebulizers or MDIs or humidifiers. Failures in the ventilators can be from electric system, microprocessors, gas supplies, or development of an internal leak. Any of these types of failures, patient safety is always the primary concern. So for that reason, you should always have a manual resuscitator at the bedside. If the patient is in distress, we need to disconnect from the ET tube and manually ventilate the patient while we troubleshoot. So we will always want to make sure that we keep our patient safe first. Okay. Finally, operator air. Mechanical ventilation is very complex. Our equipment that we use is very sophisticated. This is why respiratory therapy is a profession. This is why we're not just changing a button on the machine. You guys are going to have gone to school for 2 years. You're going to have done a lot of different things to try to help facilitate that patient ventilator interaction. So to minimize the risk of any possible error, you should make adjustments to the nobody should make adjustments to the ventilator unless they're properly trained. Okay. Even something as simple as increasing the respiratory rate can have a negative impact on the patient if the person that's increasing the respiratory rate isn't aware that that is also going to impact the expiratory time. So you want to make sure that you're trained in mechanical ventilation, to be making any adjustments, and maintaining your competencies and things like that. That's just pretty much what that section's saying. You as a clinician should also keep that in mind when you're making adjustments as well. I mean, you have obviously been trained, but when you make an adjustment to the ventilator, you don't want to change the ventilator and then just walk away without really looking and assessing your patient and making sure, like I said, you increase the respiratory rate by 2, well, stop and think about all the other things that's affecting for the patient and make sure that those are all okay before you leave that patient's bedside. Our patient safety, their respiratory safety is our kind of primary concern. So we want to just taking that couple extra seconds at the bedside is going to be really impactful. And this is something I think sometimes respiratory therapists lose sight of. It's just like, oh, I'm so busy. I've got all this stuff going on. The nurse is bugging me to increase the rate by 4. And why doesn't she just turn it up and I'll be there when I get there? It's just like, well, those things do have side effects. And again, if you value what you're bringing to the bedside and your expertise, you shouldn't be forgetting that in the moments of like being busy and asking somebody else to make those adjustments for you, because again, that's when operator errors can occur and negative patient outcomes can happen. All right, so this finishes up lecture 3.